Hello, I'd like to thank the ICS for allowing us to present our data. My name is Goueli, and I'll be presenting predictive capability of 3D ultrasound for secondary surgeries following suburethral sling removal. We have no relevant disclosures, and this was a self-funded study. Synthetic mid-urethral slings have been used for over 20 years for stress urinary incontinence. Despite their widespread use, mid-urethral slings have many untoward outcomes, including pain, dyspareunia, recurrent urinary tract infections, mesh-related issues, and voiding and storage issues requiring suburethral sling removal. Ultrasound assessment has been used previously to characterize mid-urethral slings in situ to find if there are any predictors for clinical benefit or complications of sling placement. The study highlighted here found proximal placement of the mid-urethral sling and sling to lumen diameter of 2 mm or less to be predictive for sling complications. Despite these studies, there have been no studies examining ultrasound of mid-urethral slings as a predictor of post-operative outcomes following suburethral sling removal. Therefore, we sought to determine the 3D translabial ultrasound findings that predict the need for secondary operations for mid-urethral sling-related sequelae in patients with previous suburethral sling removal. We conducted an IRB-approved retrospective review of consecutive symptomatic women referred with a history of single mid-urethral sling placement who underwent a 3D ultrasound prior to their suburethral sling removal. We excluded any women with a history of radiation, GU malignancy, history of prior sling incision or excision, or secondary operations unrelated to prior sling placement. We looked at their baseline data, their UDI-6 questionnaires, and 3D ultrasound findings, including location, sling shape, and sling to lumen distance. We broke these down into two cohorts. The first group was the patients who did not need any secondary operations for any mid-urethral sling-related sequelae following suburethral sling release, and the second group was those that did need a secondary operation. We counted mesh-related sequelae as bothersome stress urinary incontinence, persistent urinary obstruction requiring urethrolysis, recurrent urinary tract infections, and it must be noted that these recurrent urinary tract infections must have started after the initial sling placement, mesh-related pain, and bothersome urinary urge incontinence refractory to medical therapy. The 3D ultrasound techniques that we used was performed using a 3D high-resolution end-fire probe with patients either in a semi-upright or supine position. The image processing and interpretation was performed by experienced sonographers and radiologists, and we looked at three main variables: location, breaking those into proximal, middle, and distal, with proximal being within 1 centimeter of the bladder neck, distal being within 1 centimeter of the urethral meatus, and middle being anything in between. We looked at sling to lumen distance, which was the shortest distance in millimeters between the urethral lumen and the mid-urethral sling at the 6 o'clock location, and we looked at shape. And we broke shape down into 4 different categories: normal being flat along the urethra, curled if we noticed that the sling was curled under the urethra, and oblique placed sling if the sling was placed at an oblique angle to the urethra, and then twisted if you notice this twisting of the sling, which you can see by the X mark on the bottom right of your screen. The suburethral sling operative technique we used has been previously described. We initially performed cystourethropy with a 17 French female scope. We then performed an inverted U incision over the anterior vaginal wall over the suburethral sling, and then the sling was divided either at the 3 or 9 o'clock position lateral to the urethra to avoid any damage to the urethra, and it was completely removed between 3 and 9 o'clock positions. Sling arms were then dissected laterally towards the retropubic or transobturator space and removed as far as we could do safely. Any defects in the urethral spongiosum were reconstructed to avoid a pseudodiverticulum. Cystourethropy were repeated at the end of the case to ensure no urethral injury, and the vaginal incision was closed with absorbable sutures. And looking at the results, we had 131 symptomatic women who qualified who underwent a prior mid-urethral sling. After our inclusion criteria, we found that 97 women met our criteria, and 23 of these women, or 23%, required a secondary operation for sling-related sequelae. You can see the table to the right. The mean follow-up after suburethral sling release was 1.93 plus or minus 1.2 years. And as you can see on the table, there are no differences in type of sling, BMI, ethnicity, diabetes, smoking, or hysterectomy status between these two cohorts. When we looked at presenting symptoms, the most common presenting symptoms were storage issues. It should be noted that women presenting with recurrent UTIs, noting that that occurred after initial placement, more often required a secondary operation following suburethral sling release. When we look at our translabial ultrasound findings, women requiring secondary surgeries had an average sling to lumen diameter of 3 millimeters compared to 3.8 millimeters in women who did not require any secondary surgery. There are no differences in groups between sling shape or location, but it should be noted that over 40% of women had an abnormal shape of their sling on ultrasound. When we look at our multivariate analysis, and this included all of our demographics and all of our ultrasound findings, we just highlighted the notable findings here. Recurrent UTIs increase the risk of secondary surgery, and increasing sling to lumen diameter decrease the risk of secondary surgery, as you can see on the table to the right. The indications for secondary surgery are listed below, the majority being persistent stress urinary incontinence or recurrent UTIs, being about 40% each of those categories, persistent obstruction requiring a urethrolysis in about 3 patients, mesh pain requiring additional surgery to remove residual mesh in 1 patient, and persistent urinary urge incontinence requiring Botox in 1 patient. So in conclusion, over 20% of women will require a secondary operation following suburethral sling release for a mesh mid-urethral sling related sequelae. A history of recurrent UTIs after sling placement increased the risk of secondary procedures following SSR, and on translabial ultrasound, an increasing sling to lumen diameter decreased the risk of secondary surgery following SSR. Thank you. Any questions can be directed towards the following emails. Here are a list of our references. We'll be happy to entertain any questions.